Hello, everyone, and welcome to this third webinar in our 2024 science series entitled Keys to Success, Unlocking Healthcare Access for Rare Disease. I'm Erica Berg, Director and Senior Editor for Custom Publishing at Science, and I'll be the moderator for this discussion. This is our fourth year exploring the challenges and successes in rare disease. Last year, we tackled advocacy. You can read more about those conversations in the Resources tab. This year, we've shifted our focus to what we can learn from personal stories of triumph. In June and July, we celebrated mental health and caregiving wins. You can check those webinars out at science.org. Now we're turning our attention to what should be the simplest thing in the world, but unfortunately is not: gaining access to high-quality healthcare for people with rare disease. Healthcare access is a global challenge, compounded for rare diseases in which diagnostic and treatment options may be both geographically and financially out of reach for many patients. Yet, access is attainable. Today, we'll be exploring strategies to overcoming obstacles to access with our fantastic panel, which includes people with lived experience as well as experts in biomedicine, policy, and bioethics. Before we get started, I wanted to give a few instructions about the viewing console. Just to the right of the video window is the Presenters tab, where you can find photographs and biographies of today's speakers. You can log into your social accounts during the webinar to post updates. On X, you can add the hashtag #ScienceWebinar. We pre-recorded this webinar a few weeks before this broadcast, so we won't be able to take live questions from viewers, but we'll do our best to cover the topic as comprehensively as possible in the limited time we have. You can feel free to leave questions or comments in the Ask a Question tab to the right, and can reach us there if you're having any technical issues. You can also email feedback to webinar@AAAS.org. Finally, a thank you to Foundation Ipsen for sponsoring today's event and this series. I'd now like to take the opportunity to welcome our panel today. I'll give each of them a chance to say hello and introduce themselves. Here in our studio at the National Press Club in Washington, D.C., I'm pleased to welcome Elizabeth Yuko. Hello, Elizabeth.
Hi, Erica. My name is Elizabeth Yuko. I'm a journalist and a bioethicist.
Great, thank you so much. And also with us in studio, we have Jeremy Ballreich.
Hello, Erica, and thank you for having me. I'm Jeremy Ballreich. I'm an Associate Research Professor at the Johns Hopkins Bloomberg School of Public Health. Look forward to the conversation.
Thanks so much, Jeremy. Next, joining us from California, I'd like to welcome Elizabeth Curd-Halkett. Hello, Elizabeth.
Hi, Erica. Hi, everyone. My name is Elizabeth Curd-Halkett. I am Professor of Public Policy at the University of Southern California, and my son, Elliot, was treated with gene therapy for Duchenne muscular dystrophy about a year ago.
Thanks so much, Elizabeth. And finally, a warm welcome to Maurizio Scarpa, joining us from Italy. Many thanks, Maurizio.
Well, thank you very much, Erica, and hi, everybody. As you said, I'm Maurizio Scarpa. I'm a pediatrician. I'm professor of pediatrics at the University of Padova, and I lead a regional coordinating center on rare diseases in Udine University Hospital, you're always in Italy. And I'm coordinating also the European Reference Network for Metabolic Disorders here in Europe. Thank you very much for the invitation.
Thanks, Maurizio. Well, let's get started. I'm going to put the first question to Elizabeth Yuko. So what does it mean to even have good access to healthcare?
Ooh, my wish list. Well, to start with, healthcare that's affordable, that people can pay for and have without going into debt or having to make serious decisions about whether they're going to fulfill other basic needs, that is geographically close and accessible that way. Also, if you have a condition, rare or otherwise, to be able to get a diagnosis in a reasonable amount of time, not wait years or decades even to get a diagnosis, and along the same lines, have a treatment available that can ideally be a curative treatment, but if not, at least help mitigate the symptoms and also patient-centered approaches by the healthcare professionals, trauma-informed care, reproductive health care, mental health. I could go on, but I'll stop there.
Great, thank you. Anyone else have anything to add to that list? That was pretty comprehensive. No? All right. So now we know what good healthcare access is. Jeremy, could you share with us, from your perspective, what are the unique issues that people with rare disease face when attempting to access healthcare?
Yeah, that's really a great question. So outside of the clinical aspect, one of the big areas is affordability. People with rare diseases, they represent, as the name implies, small populations. In economics, when you have a small population and a treatment for that, it requires usually a price with a high premium or a high price point. Therefore, it becomes very expensive to get access to the innovative treatments. I'd also add that people with rare diseases, there's geographic issues. Oftentimes these treatments and really the stuff on the cutting edge are only available at select treatment centers. So you may have to travel, and then that raises issues about socioeconomic disparities. So really, I think the main obstacle or main struggle point, it has to be affordability.
Great. And Maurizio, I know you did this study where you were looking at healthcare access in rare disease sort of across the globe. And I was wondering if you could share with us, are there some places around the globe, or even, I guess even more locally than that, countries or even regions that do better with respect to healthcare access in rare disease? And what do they do differently? And what can we learn from those places?
Well, thank you very much for the question. I think that, for sure, now globally, there are places where rare diseases are better treated than others. We made last year a publication, as you said, going around the globe and really trying to understand how was the situation of patients of all rare diseases, not a specific group, with respect to diagnosis, to management, to access to therapy, and to research. And we found indeed that it is a sort of leopard scheme, where here and there, even inside the same country, we found different solutions, different burdens, different way of approaching the disorders and the difficulties. For sure, what we saw is that the best countries where the access and where the management of patients is actually pursued are the countries where there is a national plan for rare disorder. So where there is actually a governmental or a central guidance for the centers how to treat patients and how to have access to therapy. And this means that there is an awareness about rare diseases. So a full collaboration with patient association and stakeholders in order to attract attention to rare diseases, which are, although 6,000 to 7,000, still forgotten, especially after COVID, I have to say. And then also countries where it was working very well was where we could find registries, even national registries, in order to have an epidemiology and a statistics regarding frequency and incidence or prevalence of rare diseases. And this is extremely important because we can raise up natural history studies and we can promote drug development. Of course, we found countries where everything, like as I said, are not available, and for this there are really in the world there are still black holes regarding rare diseases. Of course, USA and Europe are the two continents together with Australia, particularly well trained for rare diseases with a lot of tradition. The USA, the Orphan Drug Act in 1983 was more or less the Magna Carta of the other plans for rare diseases. In Europe, we have still, after 2000, the year 2000, different plans, and we had the European Commission plan for rare diseases, which obliged all the member states to draft a plan for rare diseases. And now, since 2017, we have an unicum, which are the European reference networks. This is really a strategy that I think is extremely successful. I'm leading one of them for metabolic disorder, and we are grouping all the centers of excellence independently from the member states all together to work for the best of our patients and having the patients at the center. For example, the metabolic one I'm driving is formed by 100 centers of excellence, which are recognized by the local Ministry of Health and went through a very complicated grill of quality and standard assessment. And they are working all together in all the 27 member states and also UK, because we did not exclude UK even after Brexit. So I think that, as I said, the awareness, the national plan, the registry are for sure the key point to work on. So we need to help continents like Africa or even China that is now growing very well, and India, which is growing very well, on rare diseases, to align to the other continents in order to have a global homogeneity in diagnosing and treating the patients.
Great, thank you. Elizabeth Curd-Halkett, our remote Elizabeth, can you share your story about how you gained access to this gene therapy for your child, and just share your personal story on that?
Yeah, sure. Thank you, Erica. So my son Elliot was diagnosed with Duchenne muscular dystrophy in January 2020. He was, I think, 7 months old. It was a month before the pandemic. It was a very dark time. I'm a professor by trade, so the first thing I did when I got this diagnosis was I just started doing lots and lots of research. Research finds the answer. And everyone I talked to talked about this doctor at Nationwide Children's Hospital. Have you heard of Jerry Mendel? Have you heard of, he's a neurologist, he's working on gene therapy. I didn't know what gene therapy was. This is all science fiction to me. So my story starts with doctors who engage, and despite how prestigious they are, how busy they are, I emailed Dr. Mendel. I didn't expect a response, and I got one 4 hours later.
Wow.
And then he got on the phone with me and he said, I have these trials running with these young boys, and we're doing well. These trials are looking really good. And so, even in the early days of grieving this diagnosis, I had this hope. And, I'm an inveterate believer in science. So hearing this, I thought, okay. So I just started following these trials. So the reason I bring this up as the start of this is that when the FDA did give accelerated approval for Elevidys, which is the gene therapy my son got for Duchenne muscular dystrophy, I was ready to go. I had been following the trials. I had been looking at the numbers. I had seen their ups and downs, but I was ready. So I knew there were 3 roadblocks. The first was the FDA approval, and they gave a very limited approval initially and then a broad approval just last month. Or actually in June, we're in August now. And then I knew the next one would be, as is the case with all gene therapies, do you have antibodies to the virus they use to deliver the treatment? And so we actually kept my son out of preschool because I wanted no possibility of him getting these antibodies, and he didn't have them. So that was hurdle number 2. So hurdle number 3 was insurance. I knew this was not going to be cheap. And indeed, I was not wrong. It is a $3.2 million gene therapy. It is the second or third most expensive drug in the world. At the time, it was the second most expensive, and I had no idea how we were going to do this. But I worked with my insurance, and again, my son's local doctor, Dr. Ramos Platt at Children's Hospital Los Angeles, I was call her a pit bull. She fought with me. We put together the papers. She spent all her time getting this to happen. And then when my insurance authorized it, it started to stall. So this is where my story deviates from other parents' stories. So when my insurance started to stall, and my son's doctor called me and said, I don't know what's going on, but I think it's on the insurance end. Look, what does a normal parent do? They lift their hands up and they say, I don't know, I guess we're just going to have to wait and hope. But I am a professor of public policy, and down the hall from me are some of the best health economists in the world. And my dean um, is a health economist who knows insurance inside out. So, what did I do? I contacted him and I said, I'm having some problems with insurance. I'm wondering if you can illuminate. And he did. And I work at an incredibly benevolent institution where, when I reached out to anyone I knew who worked in administration and said, I need help, I don't know what's going on, they were able to help. And so Elliot did get treated. 3 weeks later, he was treated on the day we had booked an infusion room for him. It was ready to go, and he was treated, and a year later it's like a different child. It's such an extraordinary treatment for my son. He received it so well. But the feeling that I have afterwards is not just one of immense gratitude, but one of this kind of relief. Like, but wait, what if I didn't have those resources at my disposal? What do other parents do? And for me, that's the biggest challenge and the one we have to solve. It shouldn't be this hard. It should be a human right to have access to this kind of treatment.
Yeah, amazing story. Thank you for sharing. If you don't mind me asking, what was the trick with insurance?
It got blocked up in the management. I probably shouldn't go into all details here, but it got blocked up in the management component of the health insurance where they blocked it, and it got unblocked. I don't know all the mechanisms that were released to make that happen, but I do know that I alerted the people who did know. And that was a really Byzantine process. Like, I don't think I wouldn't have been able to do it without contacting people who knew how it worked. And I don't think that's straightforward for most parents.
Well, thank you so much. And Maurizio, I'm going back to you for a second. Just as your role as clinician, what have you learned as a clinician about getting healthcare access for your patients with rare disease? What is your role as a clinician in that process? And what have you observed as far as your patients who are trying to get access to care?
Well, I think that it is one of the most fascinating things that a man can do is to give a therapy to a sick child. So, I mean, indeed, whenever I can give even a tentative treatment to a rare disease patient, I'm the happiest person. I'm the saddest person thinking that 95% of other patients will never receive therapy because we don't have therapy. And this is the frustration that we are going through as clinicians every day, more or less. Because, I mean, for one patient that can have therapy, we have other 9, for whom we have just a diagnosis and then a follow-up. So this is the first thing. The second one is that really we need to give the patient the right of therapy. I'm happy, for example, that we are living, at least here in Europe, in countries where the access to treatment is, in most of our countries, ensured. At least in Italy, we have by law the right of therapy for any kind of therapy which is available on the market without any selection. And I'm a little bit frustrated by the fact that there are other countries, even here in Europe, who do not, economically speaking, the possibility of giving the therapy to patients, although they would like to give. And this makes, a very big, discussion regarding the inequality of treatment of patients and the fact that whenever you are born, you can have the right to have the therapy or never the therapy. So this is something that us as clinicians are suffering very much, and it would be extremely important to have a sort of economical solution in order to give the patients to therapy. I just come back from a very nice, incredible tour in India, where I was making lecturing in a lot of of hospitals. And for example, I was very much frustrated by the fact that in India they have a fixed amount of money per life that can give the right to the therapy only for 6 months to a year, and that's it. So I think that there is quite a lot of work to do all together with policymakers, with clinicians, with patient associations in order to find a way to give therapy to all the patients. One major problem is also to try to convince the industries not to have this huge amount of money for the therapy, which is a problem, and a problem that is never discussed enough, because that is also one of the major issue and obstacle for countries to give the therapy. So I think that we should find a way really to give the democracy of therapy to our patients and the right of the therapy to all the patients that are needing therapy.
Great, thanks. And to the first part of your point, where the issue of, for many patients, there just are not any treatments available. Elizabeth, so, these innovation therapies like the gene therapy, other Elizabeth was just speaking about cell therapies, they're brimming with promise for people with rare disease, but there's still only a handful of these types of treatments. So what is holding back the development of innovative treatments for people with rare disease? Is there enough R&D in this space so that we could at least get to the point where there are therapies that then you have to figure out a way to afford them, but just getting them?
I mean, money plays a role in that as well, because if pharmaceutical companies don't think that they're going to make the money back, and then many times over, there's not much of an incentive for them to put the money into the R&D. But beyond that, with certain rare diseases like sickle cell disease, for example, you have other systemic issues at play, because there are, I think, roughly about 100,000 people in the United States living with sickle cell disease, and the vast majority are of African descent, although there are people of other ethnicities who have sickle cell. And this is something that Harriet Washington writes about in her book, Medical Apartheid, how sickle cell has been classified as a Black person's disease for decades, and for over 100 years at this point, because the sickle-shaped cells even were first identified in 1910, and then in 1949, sickle cell disease was the first disease examined on a molecular level. So by all accounts, it shouldn't have taken until this year, end of 2023, to have these curative treatments approved. And so that, I think, unfortunately, is part of it. And along the same lines, it's probably also very underdiagnosed, because some members of the medical profession might ignore pain of Black Americans, for example. And so someone who may be living with sickle cell disease may not get that diagnosis, and then may never get that treatment, and they're not that included in the numbers of people who need that type of treatment. So it's a big cycle.
Yeah. And Jeremy, I think someone mentioned the Orphan Drug Act, and I think, if my memory serves, sort of it's to help bridge that divide and help spur research and development for these innovative therapies. I was wondering if you could talk a little bit about sort of policy and how that maybe helps, or what else can be done, I guess, from here. I guess what was in the early 80s that came online, and we still have so many rare diseases without any treatments.
Yeah, in 1983, Henry Waxman was one of the original sponsors of the Orphan Drug Act, and it's really a remarkable piece of legislation. It helped spur development into rare diseases. It provided tax credits for companies to do R&D. It also provided market exclusivity. So when a drug became approved and commercialized, the company could make back their money. In pharmaceuticals, you have a tremendous investment, very high risk investment up front, and you only recoup that if a drug gets approved. And approval, it's a dice roll, to say the least. There's a lot of hurdles from laboratory science to actually getting it working in a human body, safe and effective. So the Orphan Drug Act, it's been around, had a couple changes with the Trump era tax cuts. They reduced the R&D tax credit by a little bit, but market exclusivities is a major component. Outside of that, there's several other areas of policy. Elizabeth mentioned sickle cell disease. This area where President Biden, he announced back in October 2022, he tasked CMS, Centers for Medicare and Medicaid Services, to look at access programs for high-cost drugs. Sickle cell disease, last year we had both exa-cel and lovo-cel, 2 gene therapies approved for sickle cell disease. And CMS is now working to develop a policy model called the Cell and Gene Therapy Access Model, looking specifically at those 2 drugs, where they'll partner with Medicaid programs using innovative payment. And the idea is to improve access, because this is a population, again, as Elizabeth pointed out, disproportionately African American. It's also disproportionately covered under Medicaid, which, for the audience who may not know, Medicaid is a public payer in the US, but it's also one of the more financially constrained payers. So there are policies, there are, both at the federal government, there's also a number of state initiatives to try to spur research and development in rare diseases. California had a big stem cell initiative. And there's also additional policies to really kind of think about in terms of ensuring that when a treatment gets to the market, that people have access. And that's not only beneficial to the patients, but it's also a benefit to industry, because they want to be able to sell the drug, and access is how they sell the drug.
Thank you. And Elizabeth, so sort of between the R&D and the approval is this sort of the experimental stage, right? All the clinical trials when they're testing for safety and whatnot. In California, Elizabeth, I was wondering, when you were first learned about the gene therapy for your child, it was still in sort of clinical trials. And I was wondering if you could talk a little bit about how the FDA decision sort of impacted your ability to access that treatment and how that plays out with your insurance coverage.
So the FDA has a mechanism for approving treatments prior to the phase 3 results, or of coming through yet, and it's called accelerated approval. And if my memory serves me correctly, I think that Elevidys, the gene therapy for Duchenne muscular dystrophy, which Elliot received, was the first treatment under accelerated approval. Now, this is an amazing mechanism to get these life-saving treatments to a patient population as soon as humanly possible, okay? Because with progressive degenerative diseases like muscular dystrophy, if you get the treatment at 4 versus 5 or 6, it's a big difference in how you receive it. Even if it's effective across age groups, it's most effective when you get it early. So Elliot really benefited from that. And my insurance company did actually approve treating him. However, I have heard multiple stories that accelerated approval is also a loophole for insurance companies to say, this is investigational. It's also really expensive investigational. So we're going to go ahead and wait until it gets broad approval. And so that's the problem. It's actually a double-edged sword. On the one hand, it is this way that the FDA, and thank God for Peter Marks, approved this accelerated approval because it gives this treatment to patients. But on the other hand, insurance companies can say no. until it's fully approved, and that can be a lot of time. I mean, it was not quite a year, but it got broad approval in June, and Elliot received it in August. So actually, no, it was about a full year from accelerated approval to broad approval.
And did you have any, I mean, with the accelerated approval, did you have any sort of safety concerns at that stage, or you were just let's go for it? And I want to talk a little bit about sort of the safety issues with experimental treatments.
Look, Elevidys is a very safe treatment. That's the thing. I mean, there have been other problems with other trials for sure. But one of the great things, and one of the things that was very reassuring about Elevidys, was the only thing I needed to look out for was efficacious treatment, not safety. So, but yeah, safety can be an issue. But I think that's one of the things that the FDA is very, very focused on. So I wasn't super worried about that.
In studio, Elizabeth, do you, I guess, getting to that safety issue again, from your bioethics background, what can you tell us about what we should be thinking about when giving access to an experimental treatment?
So if there are approved treatments for a rare disease that a patient might not be able to afford, and then they are also given the opportunity to take part in a clinical trial or try an experimental treatment, they're then in the position of having to weigh the potential risks and benefits of this treatment. And safety is certainly one of them, especially in the earlier stages of research, that when the safety profile isn't as well known. And so a patient and their family may be forced to make the decision of, okay, if I can't afford this drug, should I try this experimental one, which might work and might not? The safety, should I offer myself as a research subject? And I mean, of course, that depends on many different factors, including how advanced someone's condition is. But it's this additional level of complication that some people have to face when they're given that option. And they're not always going to work. Kind of what Jeremy mentioned before, there are so many experimental treatments that never make it to market and never get approved, that we just don't know about. And so even though it's not something we hear about on the news a lot, it is happening. And so, and behind those trials are people who've had to make those decisions and just, weighing the risks and benefits of each treatment.
And I think we've been maybe a little US-centric. Maurizio, I was wondering if you could talk a little bit about how this works in sort of the European model, maybe a little bit. How do, innovative therapies, is it the same sort of clinical trials, accelerated approval, that kind of approach, or do you have sort of your own model?
Well, I mean, I think that the model is more or less the same. With different timing and with different approaches regarding some local regulation. But I mean, the clinical trial per se is a very standardized procedure. I mean, regarding safety, that was just the topic of discussion up to now. I mean, as clinicians, we cannot try any substances without a proper project or a proper experiment first before clinics and then in the clinics. Then, of course, there are all the procedure of phase 1, phase 2, 3, and then the phase 4 before marketing. And then even during marketing, there is the need of following a little bit the safety and efficacy of the therapy with patients. So I think that, as a clinician, I feel very confident that when there is a new drug to be tested, of course, all the tox data, all the safety data, at least at preclinical level, have been done. There is, of course, a very rich documentation about that. There are a lot of publication before making a clinical trial. And even in off-label or drug repurposed action, a drug. I mean, there is now a repurposing of a drug because we have so many millions of drugs that were not successful for the original disease that now can be shifted to another disorder. Even that, of course, is something that is safe in my opinion, because all the tox data and the safety data have been done even in human, for the trials and for the diseases for which the therapy was studied for. So as physicians, we are really devoted to the safety of patients. We will never harm the patients. We will never do anything to get the patients worse than what it is. And as I said, the frustration is actually to see that, unfortunately, the clinical trial for rare diseases in particular are made only with few patients. So the selection for a clinical trial is very strict. Most of the time, a lot of patients are excluded by the clinical trial. So there is a frustration for the family and for the patients not to be included. When the clinical trial is finished and there is an idea of working, probably sometime we don't have, the time to give before approval, the drug in a compassionate way. So the patient has to wait until the drug is on the market, and in the moment of publication up to the approval, it varies quite a lot according to the different country. The patient might receive the drug, but actually they cannot because there is not a compassionate system. And then whenever there is the approval, then it is the accessibility is related to the member states or to the state economy. So as you see here, there are a lot of steps, a lot of obstacles that are actually, giving the patient an opportunity to get the therapy. And I think that globally speaking, we should really find a way to have a connection between the different agencies, connections between the different researchers, the possibility of whenever the drug has been found safe and eventually efficacious, also to find a way to allow the patients to enter in a compassionate system up to when the drug is on the marketing. So we really and we desperately need therapy for these patients, and to try to shorten as much as possible globally the access of the therapy to the patients.
And I'm curious, so for clinical trials for treatments for rare disease, are there typically sort of geographic limitations on who can be in those trials, or are they typically open to anyone with that disease? Or does it vary?
Is it for me?
Yes, please. Or anyone, if anyone knows.
But I can start. I mean, unfortunately, I have to tell you yes. Yes, because I mean, first of all, whenever you start from scratch, the trial, you need a phase 1 center. A phase 1 center means that it is a center in which you can really test a never tested before drug on a patient. So all the preclinical has been done, but you always have the doubt that something can get wrong. And so you need a specific equipment, you need a specific clinical trial team that is prepared for any kind of bad accident that might happen to the patient. So we need phase 1 trial centers, and phase 1 trial centers are not worldwide distributed in a very homogeneous way. Even in Europe, we have quite a lot of phase 1 trial center, but I mean, usually what it is directing the access is actually the decision of the sponsor. The sponsor, the company, if it is a drug from a sponsor, from a company, usually want to have the clinical phase 1 trial center better in the US before than in Europe. So, for example, there are a lot of drugs starting in the US, and then we have in Europe, and then in the other side of the world. Of course, it depends a little bit not only from the phase 1 trial center, but also from the availability of patients. As I said, the number of patients for the clinical trial in rare diseases is minimal. You can have even a trial with 4, 5, 10 patients as a whole. So you need also to find a way where the patients live and how they can access the hospital. And then, of course, there is the expertise of the different centers, in the trial, in the clinical trial. So there are a lot of factors that are directing the choice, to start a totally new drug or to expand, to grow the number of patients to be tested throughout the world. And usually the centers that are selected are the centers, of course, with major expertise. So in Europe, we are part of that. And in our network, we have more or less all the center for this. And we indeed have the possibility of treating patients.
Okay, I want to stick a little bit on the geography issue a little bit, because that I think is one of the major obstacles to healthcare access. And we talked about this a little bit before, but so in May of this year at Children's National here in Washington, D.C., the first patient began sickle cell gene therapy after it was approved by the FDA. So once it was approved, lots of people had the drug in clinical trials, but this was the first person to get it after they were approved here in DC. And it's a therapy that costs millions of dollars, similar to the drug that Elizabeth's child received. And millions of people have sickle cell disease across the world, so it could cure millions of people. But will it? And what are the financial and I guess geographic? When the FDA approved this drug here, I don't even know if people in Europe could access the drug, or just from the drug is here. Do people have to come over here and get it if they want it, or if they can't afford it? So what are the issues at play?
I mean, not to keep going back to it, but affordability really is, because a treatment can exist, but it can only be as effective as it is accessible. So if there are millions of people, for example, there are the highest percentage of people living with sickle cell is in the African continent. There are also large populations in the Middle East and Southeast Asia. And in lower and middle income countries, they might not have the medical infrastructure to be able to treat patients with these innovative gene therapies, for example. And so cost aside, that's one issue. But then, cost is, you can't ignore that. And if we're developing these treatments that are costing millions of dollars, that's essentially leaving out the rest of the world that can't afford that, and even many people in the United States who can't afford that, and saying that certain groups are more deserving of treatment than others, and that's certainly not the case. And one of the main principles of bioethics is justice, that the benefits and burdens of research are shared, and that's not happening if people aren't able to benefit from emerging treatments.
And Jeremy, you mentioned this briefly, but I was wondering if you could talk a little bit more about I think it was called the Cell and Gene Therapy Access Program. Sort of what is it? Who might benefit from it? How could people learn more about it if someone watching might want to know?
Absolutely. So, I think for what we call payers, this is Medicare, Medicaid, health insurers. If you're in Europe, some of the governments where they're the major payer for your health care. They're looking at unique payment models, not just simply pay per pill, but thinking about models where they make an agreement with the drug company that if your drug delivers what it was shown in a clinical trial, we will pay, but perhaps if it doesn't deliver quite exactly, we'll pay a little bit less, or or a penalty. And this is really important in rare diseases, in part because we touched upon this earlier, where clinical trials, one, they're really small. Two, they're also fairly restrictive to what patients can access them. For like the sickle cell disease trials, if you had any number of comorbidities, you were excluded from being eligible for the trial. So the drug's approved in this more ideal patient population and then sold or marketed to a larger population. So payers, when they're looking at $1 million, $2 million price tags, they want to make sure they're getting their value. And this is where unique payment models can take place. And the cell and gene therapy access model, this is a unique payment. It's technically called the outcomes-based agreement model, where Medicaid's working with the manufacturers of exa-cel and lovo-cel, the two gene therapies for sickle cell disease, to ensure that Medicaid patients can get access to these drugs, but at the same time show that these drugs do what they should do or what they demonstrate to do in the clinical trials. It really kind of ensure that the healthcare system is getting the value that is expected when you pay a couple $1 million for the treatment.
And is this in effect now, or is this something that is?
This is ongoing. It's not in effect yet. Well, the access program is in effect, but they're still through the process. So patients are not getting access to this drug yet through the access program. I believe CMS is expected to have patients getting access to this drug next year under this. I personally think it's a very aggressive timetable, but we'll see.
And so under that, so Medicaid recipients could have access to sickle cell gene therapy under this?
If their state opts in to agree with this.
The state,
So this is,
Yeah.
we talk about geographic,
yeah.
And this is a situation where your zip code and your state can determine what drugs you have access to, unfortunately.
Wow. Is there anything similar happening in Europe in terms of programs that are helping people gain access to cell and gene therapies, Maurizio? Or how is, or is it also sort of a very local?
Yeah,
It's
it is
country
a
by
very
country.
local.
Yeah.
Yeah, it is a local decision. We are working at the European system. There is a big discussion on a cell and gene therapy access. Of course, the cost of this therapy is really something to discuss about. And there are quite a lot inside the European Commission and the European Union, a lot of discussion with stakeholders in order to find a sort of regulation, a sort of indication and recommendation at central level for all the member states. But then the single member states have the authority, to decide for the country. And here is where then the trouble comes, because of course, it depends from the economy, from the number of patients, from the activity of the patient association, and the expertise of the different centers. Of course, when you're speaking about gene therapy, we are ready to have patients going cross-border, because you cannot make a gene therapy, drug or treatment in any kind of hospital, even a very peripheral hospital. You need to have an expert center. So what we are thinking is indeed to elect some centers per country who will apply this therapy. Of course, numerous centers, so to decrease as much as possible the burden of the patient to travel. And so there is quite a lot of discussion about.
And with all these therapies that are emerging, there's going to be more and more of these very expensive but amazing treatments available. And I'm sure people with rare disease would, love to have access to these, life-saving therapies wherever they are. California, Elizabeth, I was wondering if you could share what your thoughts are on how people and caregivers in rare disease, how could they advocate for healthcare access?
So I think, I was really moved by some of the comments made by Jeremy and Maurizio, because there's this other layer of geography and disparity that's at play, which is, this is my area of research when I'm not advocating for my son, which is cultural and social capital. So, even to get access to a trial, you have to be affiliated with a major research center, or you have a doctor who is really in the know of where these trials are going. You also have to have a job that is somewhat flexible, where you can go and be seen. Because these trials, it's not just with Elliot, he got the treatment under approval, so he was treated and he has follow-ups. It's very different when you're in a trial where you have to be evaluated every few weeks, every month. You have to travel. That is a lot of not just financial burden, but it is the network in which you have healthcare, the doctors you work with, the time you have on your hands. So I think I wanted to add to that conversation that it is also complicated in ways that are somewhat nebulous and very, very hard to track. So with regard to getting access, and it's not just for Duchenne muscular dystrophy and ELEVIDYS, but in general, I think, so I'm a very private person, so even being on this webinar is a lot for me. When Elliot was treated, I moved from feeling like the most unlucky person in the world to the luckiest person in the world. And I felt a tremendous duty to give back. And so I wrote this essay for the New York Times about my experience. It got a lot of attention. And in fact, my colleagues, some of them hadn't even known what our family was going through until they read that essay. But for me, it was, okay, the system, the treatment, science worked for you. So this is your time to give back. And so what I say is, you have a voice and use it. You also can help other patients and parents. So one thing I've really been very clear with, particularly with my son's neurologist at Children's Hospital, is if there are parents navigating insurance and they need help, give them my phone number, because I am happy to give any time that they need to helping them write their letters, go through things. You've got to give back in that way. The other thing is, these agencies, the FDA, they want to hear from you. So I have emailed Peter Marks, who's the head of the center that approves gene therapy in the United States in the FDA, and I've emailed him multiple times. I don't believe that my voice is disproportionately influential in any way, but I think every bit counts. So when Elliot was treated, I was able to say, hey, Dr. Marks, my son's doing really well. I know you're considering this treatment. If you need any more information or evidence of how this is effective for many boys, here's another video of my son running and jumping. So I think that's really what you can do to help others, is if you have been so lucky to be blessed by science and to have had a good experience, to try to help others have that experience too, in whatever platforms or avenues are available to you.
Anyone else?
May I jump in the discussion?
Yeah, please.
No, I appreciate very much what California Elizabeth is saying now, and that is extremely important to collect all the patient-related outcome measures that actually can really show the efficacy of the therapy. This is something that is stimulating a very big discussion in Europe and worldwide regarding the PROMs and the PREMs, so the patient-related outcomes and experience. Because I think that it is not only a number or a biochemical measure that is actually deciding whether the therapy is indeed working or not, but it is the experience and the quality of life and the changing of the quality of life that is extremely important for the patients. Nevertheless, I think that we need to have more science in the clinical trials. We need indeed to start working extremely hard with the search of biomarkers, because it is true that the therapy can change the quality of life of therapy, even not showing very much some biochemical effects. But it is also true that some biochemical effect might change much before then the clinical effect is appearing. So we really need to make a lot of science. We need to make a lot of studies and basic research in order to understand better the pathophysiology of the disorder, to understand what is the best biomarker to be used in order to be using the best biomarker before the treatment, during the treatment, and during the extension time. Then we can really have, the full understanding of the real safety and the efficacy of the drugs, because we have to remember that unfortunately for us, the drugs are not only few, but they are also very young. So I think that not all the efficacy of the drugs have been studied yet. We need years to study the patients, and so we need also the companies to embark in a long-standing study for the drugs and not finishing, whenever the drug is on the market, because that is the moment where indeed the drug is showing whether it works or not, when it is used by the biggest number of patients possible.
I guess to jump off of what California Elizabeth was saying, living with a rare condition can be a very lonely existence, and sharing information, whether you are doing so as a caregiver, as a patient, with other people who are going through something similar, is hugely valuable for other people and such a great way of using what you've learned to help other people. And so I think that's so great that Elizabeth's doing that for other parents. And I was involved in the caregiving of someone with a rare disease who's no longer here, but that was one thing that she loved to do. Any opportunity to help anybody else going through this was just beneficial for her mental health as well.
Amazing. And I know you talked about, reaching out to the FDA or working with other families, and we've talked about the cell and gene therapy access program that is still in its early stages. But are there other programs, and are there ways for advocates to reach out to government, Congress, people who are involved in these sorts of decisions, and what should they be focusing on? What of the policies that are sort of in play should we be spending our time advocating for?
Yeah, I mean, it's a really great question. I testified earlier this year in front of Congress on policies for rare disease, and they had, I believe it was around 23 different legislative proposals that touch upon rare diseases. And
23?
23. It was tremendous. Some of them, it was just obvious. For example, one of the big issues is if you had Medicaid and your state, let's say you lived in Ohio, but you needed, let's say the only hospital that offered a certain unique therapy was in Maryland, and Ohio Medicaid said, sure, we'll pay for it. They needed to make sure the Maryland doctor and the provider would be enrolled on Ohio Medicaid provider networks, which can take time. And for parents and for patients, time is incredibly valuable. And there was a legislative proposal to streamline that. There are some obvious policies out there to improve it. Once that it's bipartisan, it's just a matter of actually getting the policy approved and signed into law. And these little things that can help, improve access. And I think also just generally when we think about access to rare disease, we're really just now beginning to benefit from the tremendous investment that was done at the Human Genome Project, back in the 90s, the $5 or $10 billion. We're now beginning to reap those benefits. And I've seen projections where there's going to be between 20 to 30 gene therapies approved a year going forward. So, we're going to start seeing a lot of new drugs for a lot of rare disease. I think it's a situation where patients, caregivers, parents, you want to be informed what's out there. You want to ensure or advocate to make sure that even once a drug gets out there, that it can be affordable.
Well, not to look forward to. Unfortunately, we'll have to stop there as we've run out of time. Many, many thanks to our panelists today. It's been a delight talking with you all. I learned so much, and I hope our audience did too. A reminder to our viewers that you can see a recording of this webinar as well as all the previous events in this series at science.org/webinars. This webinar is the third in a series of 6 running this year, so look out for more soon. If you'd like to send your thoughts, email us at webinar@AAAS.org. Also, I wanted to let you know that in just a moment, you'll be invited to fill out a brief survey. Your responses are so important and will help guide future conversations on rare disease. Thank you once again to our panel and to Foundation Ipsen for enabling this conversation through their kind sponsorship. Goodbye, everyone.